Assalamu alaikum wa rahmatullah. So after we're done with the trauma lectures, basic trauma lectures, now we're moving to one of the most common complications that we're having in orthopedics, and after the intra-articular fractures, which is osteoarthritis and the related disorders. So basically osteoarthritis, usually it's a chronic disease of synovial joint in which progressive softening and disintegration of the articular cartilage. So basically it's a problem for the articular surface, for the cartilage. And as you all know that the cartilage is one of the tissues in the body that does not regenerate. So the tissues in the joint, if you have an articular surface, if it's got damaged, it will be replaced from hyaline cartilage into fibrocartilage, which has some different components, water fluid content. That's why when you have injury in your cartilage, it will never be replaced with cartilage another time. A lot of studies is going through these injections that, it's coming to the market nowadays, but nothing proved yet to regenerate cartilage. So new growth of cartilage, bone and joint margins. You have osteophytes. We will talk about the pathophysiology, cyst formation, sclerosis in the subchondral region, and synovitis. Okay, it is like the most common form. Okay, it is unaccompanied with any systemic illness. So it's very common old age. Most of the old people after the age of 50, 60, they have stiffness, pain, swelling in the joints, in the synovial joints. So this is mostly like primary inflammatory disorder. It's the primary osteoarthritis. If it's secondary, there will be underlying cause we will be talking about in a bit. So weakening of the articular cartilage, increased mechanical stress. So this is the causes, because it's getting more weak with age. And the other thing, increased mechanical stress. So if you have an old age and, for example, he's getting up the stairs every day, he cannot relate this as a young adult. So increased stress, excessive impact loading, reduction of the articular contact area. That's why the joint is trying to make the surface wider. So it's making new osteophytes. These osteophytes, the function of it is to make the articular surface wider, so less pressure on the joint. But the problem is, after some time, when the osteophyte gets bigger and bigger, it will get broken and it will go inside the joint. It will be named a loose body. So osteophytes to increase the joint space, loose body after the osteophyte is broken inside the articular surface. Defects in the subchondral bone because of the stress inflammatory process. Okay, in the early stages, usually the damage to the cartilage, the collagen network, and loss of the proteoglycans. This is very important to keep in mind the basics of the cartilage. Pathology, progressive cartilage destruction. So we have more and more destructive. Subarticular cyst formation. Why this is happening? So as you know, one of the cardinal features of osteoarthritis that you will see subchondral sclerosis. Because of the inflammatory process, there will be more inflammatory markers going on, more sclerosis, more deposition of calcium. And the easiest way to deposit the calcium in here is to move it from the subchondral space. That's why you will see sclerosis, and below it, cysts. Okay, that's why we have subchondral cysts, subchondral sclerosis, osteophytes to increase the joint space, and capsular fibrosis. Nice picture. It's giving a comparison between the osteoarthritis and the normal. This is the normal capsule. In the osteoarthritis, you can see that it's much more thickened. You can see destruction of the cartilage, here the normal cartilage. The synovium is hypertrophied, and we have something called synovitis. So synovium and itis, so it's inflammation of the synovium. We have sclerosis, subchondral sclerosis, just below the chondral bone. Here you can see that it's sclerosed, more white on X-ray, and below it, the cysts. And in the later stages, there will be deformity and altered contour of the bone. Sometimes in the knee, you can see genovarus or genovalgum, depends on the deformity. So more load, more loss of cartilage, more serious disease. We have something called chondromalacia. Chondromalacia seems it's like a stage of this disease, but it's only for the patella. Okay, so for the patellar cartilage, which is the thickest cartilage in the body at 7 millimeters, because it's having a lot of load, as we talked in the last lecture. So when you have patellar articular surface osteoarthritis called chondromalacia or runner's knee. So the pathology, you have subarticular bone reacts to the changes in several ways. So there will be cysts, there will be sclerosis, there will be vascular congestion because there is inflammatory process, the interleukin cytokines, there will be vasodilation in the arterioles and the venules, shifting of the fluids from the intravascular to the interstitium, more pressure, so the intraosseous pressure is getting more and more. We already talked about the osteophytes. The remodeling process restores a measure of congruity, increasing malopposition joint surface. So that's why the deformity, how it's going on. And capsular fibrosis. Osteoarthritis is the most common type of arthritis. So we have a lot of types of arthritis. The most common, osteoarthritis. Primary or secondary? Primary is the most common. Secondary, we have many causes. Okay, osteoarthritis is uncommon in adults usually, but after 40, 60, it will be getting more and more. What are the joints? Synovial joints usually, the commonest. We have in the cervical, lumbosacral, hip, knee, metatarsophalangeal joints, and distal and proximal interphalangeal joints. Risk factors. So for the risk factors, we have the hereditary and we have the acquired, okay? So hereditary, it's genetic, family history, high bone mineral density, and so on, and aging, okay? And then the mechanical factors. So for the mechanical factors, which will cause you secondary osteoarthritis, usually it's trauma, joint shape, alignment, usage, or occupation. Trauma, especially for the intra-articular fractures, which are mal-reduced. They are not reduced very well. You remember anatomical reduction, rigid fixation, it was not anatomically reduced. It will increase the risk of osteoarthritis. Symptoms. The patients will come to your clinic usually, or if the pain CV into the emergency room complaining of pain. Always, it's pain and pain and pain. Cartilage per se, there is no pain endings in cartilage. So the patient will not complain from the cartilage itself, but from the things around, which is the ligament, the capsule, the synovial, and the muscles, and the subchondral bone. So these are the things that will cause him pain. So mild synovial inflammation, capsular fibrosis with pain, muscular fatigue, and the bone pressure will be increased because of the inflammatory response. So typical characteristic pain, how the patient will present to your clinic. Usually patient over 45 years. The pain is insidious over onset, months to years, variable or intermittent. So they have some good days, say they have some bad days, depends on the activity they are doing. So the patient will be complaining, when the patient when he's trying to go to the clinic, he will book an appointment. And sometimes it takes, for example, 2 to 3 weeks to get the appointment. After 2 to 3 weeks, when he comes to the clinic, he will complain that I used to have pain like for 2 weeks, now it's better. That does not mean that the thing was resolved, but they have good days and bad days. In the morning stiffness, it's less than 30 minutes. Then it's gonna be okay for the rest of the day. Few joints, okay, not multiple. In late stages, if it's severe, they will have pain in bed, okay? Like even if they're sleeping, they will be complaining of pain. Stiffness is like because they are having pain, they are not moving the limb too much, the joint will be more stiff with the inflammatory process. So stiffness, it's like a vicious cycle. More osteoarthritis, more pain, less movement, more stiffness. So this is the pathophysiology of it. Swelling, for sure, inflammatory process, deformity in the late stages, and loss of function sometimes because of the severe pain, and it's stiff, it's not moving anymore, so there will be loss of function. This is in late stages. Signs. When you examine your patient, you will see that there is decreased range of motion, which is restricted movements. You can feel crepitation. So when you put your hand on the knee, for example, and you do flexion extension, you feel that there is crashing like movements under your hand, like it's crepitations. Bony swelling, sometimes if you can feel the osteophytes, and deformity. If you look by inspection, you can see it's asymmetrical sometimes if it's in one joint, or you can see the genovarum, genovalgus, and so whatever. Around this joint, there will be muscle wasting, disuse again. Disuse, muscle wasting. He's not using the lip, so more osteoporosis, and that's all. Nice pictures. On your left side, you can see here geno. It's going to the outside, so it's geno valgus. Okay, geno valgus. It's called knocking knees, and here geno varus is going inside to the medial aspect, which is called bowing. So knocking and bowing. X-rays. It's very important to diagnose osteoarthritis by X-ray. Don't rush into MRI, because we have a common mistake. It's international. Whenever you find a patient who's in 60s, he's complaining of knee pain, let's go and do MRI. MRI is costly, it needs time. It's not good to send the patient to MRI because it will take a long time. Sometimes it takes months for this patient to take this or to do the image. So just go for simple X-ray and you will see the nice cardinal features of osteoarthritis, which is decreased joint space, osteophyte, subchondral sclerosis, subchondral cysts, and deformity. And sometimes you will see the loose body. So these are the main aspects you will see on X-ray. Let's see a normal X-ray. So this is a normal X-ray AP with the good exposure. You can see the distal femur and the proximal tibia and fibula. You can see the patella. You can see the joint space. It's very nice. There is no deformities. There is no fracture lines. This is normal. But here you can see a standing AP. So usually when we want to assess a weight-bearing joint like the knee, we have to do a standing X-ray. Standing X-ray. So you want to see the compression on the joint and you want to see the articular surface. If your patient is supine, he's not standing, so there is no pressure, you will not see the severity of your osteoarthritis. Look at this picture. Joint space completely damaged. Subchondral sclerosis everywhere. Cysts, a lot of cysts. Osteophytes are here, osteophytes are there, osteophytes are here and here, everywhere. Deformity, if you look at the angle in here, you can see that this is geno varus, so it's bowing on the knees. The medial aspect usually it's more affected than the lateral because more of your weight or most of your weight is going through the medial aspect. So varus deformity, severe osteoarthritis, and even it's subluxated. It's not dislocated, it's subluxated. So this is a very nice late stage osteoarthritis X-ray. This is osteoarthritis in the shoulder. You can see the humerus, you can see the glenoid, decreased joint space in here, subchondral sclerosis, cysts, everything. We already talked about this. Now types of osteoarthritis, we have the monoarticular and polyarticular. The classic osteoarthritis is presenting with pain for sure. One or two of the large weight-bearing joints because of the continuous pressure. It could be primary, secondary. Why secondary? Because of epiphyseal dysplasia, DDH, developmental dysplasia of the hip that we will be talking about, Perthes disease, slipped capital femoral epiphysis, inflammatory joint, rheumatoid arthritis, so whatever. So these are secondary, and we will talk on each disease separately in the lectures gonna be coming soon. Okay, osteoarthritis, we already talked that it's most common 40s or 50s, distal to proximal. We have some nodules, Heberdens and Gauchers. You can see here, Heberdens and Gaucher, the difference, the DIP and PIP. Okay, interphalangeal joint. You can see the difference between these two signs. Complications. Sometimes there will be capsular herniation. You remember from the last lecture, we talked about that each synovial joint has a capsule. This capsule is to maintain the synovial fluid inside. So what will happen if the pressure inside this increases? There will be herniation. And one of the most common, it's called Baker cyst. Baker cyst is in the posterior aspect or the posterior capsule of the knee joint. It will be increased, and sometimes it will give compression to the neurovascular bundle and will cause pain with paresthesia and, So loose bodies, if there is a fracture or if the osteophytes get fractured and inside the articular surface, sometimes you'll have the rotator cuff dysfunction like the acromioclavicular joint, spinal stenosis in the spine. What are the differential diagnoses? It's AVN. So avascular necrosis, as we talked in the scaphoid, in the talus, in the head of femur, sometimes it's because of trauma, but sometimes it's happening just on by on. So pain and local effusion, joint space usually is preserved. Joint space usually in the early stages is preserved. Why? Because the cartilage is taking its nourishment from the synovium, okay? So it is not affected. That's why the joint congruity usually in the first stages is not affected. Differential diagnosis. So we're done with the avascular necrosis, inflammatory arthropathies like rheumatoid arthritis, Reiter's disease, polyarthritis. You can think about psoriatic arthritis, gout, and so on. How to manage? The most important part in the management of any disease with osteoarthritis, because the patient is complaining of pain, so you have to give painkiller. This is one of the most important. Painkillers, paracetamol or brufen or non-steroidal anti-inflammatory drugs, usually it's inflammatory process. That's why we prefer to give non-steroidal anti-inflammatory drugs. Physiotherapy is very important to decrease the stiffness, maintain joint range of motion, maintain your muscle power, okay? So it's very important. The more you have strong muscles, the better the pain will get. Reduce the load. Sometimes we can give the patient crutches to use to decrease the load on the joint. And sometimes a lifestyle modification is very important, not to use stairs. For Muslims who are praying, not to sit on the floor. If you're going to the bathroom, don't use the bathrooms on the floor, use the traditional ones. So it's important to change the lifestyle of your patient, reduce the weight, for sure, it's very important. Okay, if the treatment, the conservative, is not working, what to do? Sometimes if it's primary osteoarthritis, yes, you can, for sure you have to use ice, rest, non-steroidal inflammatory. If it's not working, what to do? The next step, injections might work. Cortisone injections, it's evidence-based. Sometimes they give hyaluronic acid injections. It is not evidence-based yet, at least. They have a lot of studies on. Some patients are getting benefits, some patients are not. So it's controversial now. What about procedures? Procedures, sometimes they are okay for the patients. Okay, for the knee joint, for example, you go in, you do debridement, you remove the osteophytes, the cartilage, and so on. If your patient is young, you can do realignment osteotomies. If there is more pressure on the medial aspect of the knee, sometimes we do osteotomies and realign the knee so we can distribute the pressure if he's young still. And the knee is stable. But in the late stages, it's impossible or it's hard to do this. That's why we go for joint replacement, which is like total knee replacement. In younger patients, sometimes you go for arthrodesis. Arthrodesis, which is to fix the joint, no more joint. We go in, we debride the cartilage, we put the bone on bone and plate it. So there is no more joint. And we put the joint usually in the position of function. Neuropathic arthritis, which is called a Charcot disease, this is very common for the poorly controlled diabetic patients. You know that one of the pathophysiology in the diabetes, they have peripheral neuropathy. So the pain sensation is gone. Pain is very important to protect the joint. So they will have trauma, there is no pain, more trauma, there's a vicious cycle going on and on and on. And they will get unstable swelling and deformity in one of their joints, usually in the lower limb because they are weight bearing. And you will find on X-ray a destructed completely joint with no complaints, that the patient is not complaining of pain because he's not feeling. You can see on this X-ray here, destructed completely joint with in the first tray. And you can see here in the third, the second already got amputated. So miserable life for these patients. Hemophilic arthropathy. So in hemophilia, you have the Christmas disease, it's called. So it's a rare X-linked recessive disorder. Usually these patients bleed very easily. And if they are bleeding inside the joint, they will present with limping, unable to bear weight, swelling, pain. The problem is, don't do aspiration. It's very bad if you go and tap these patients because there will be more and more and more bleeding. You will give them a raise in the incidence of infections. And if he got an infection, thank you very much. So be careful. Don't tap these patients. Only give them painkiller, ice and ice and ice, rest, splint them until it's better. This is the presentation for hemoarthrosis. Treatment is not an orthopedic specialty usually for hemophilia. They have to be treated by the internal medicine doctor. Cryoprecipitates, fresh frozen plasma. Aspiration is avoided again and again. Acute bleeding into muscles, it's painful again, and it may cause compartment syndrome. That's why patients with hemophilia who are complaining from pain, be careful, compartment syndrome again and again. So treat with splintage, rest, ice, compression, elevation, and physiotherapy. And lately you can do some operations to correct the joint deformity. This is for the osteoarthritis. Let's go for osteonecrosis. So basically it's either traumatic or atraumatic. There is trauma or there is no trauma. There will be vascular anatomy of the bone, as we already mentioned in the first lecture, which is the periosteum, we have the nutrient artery, we have the metaphyseal arteries, we have local hemodynamics. So what's happening, when there is inflammation is happening, there will be ischemia, more edema, marrow swelling, more interosseous pressure, which is a vicious cycle. More ischemia, more edema, more swelling, more pressure, and more until the bone dies. So the vascular anatomy is very, very, very important. And you know the most common sites is the femoral head, femoral condyles, head of humerus, the capitellum, the proximal part of the scaphoid, and the talus. And that's why, because the pressure, it's a vicious cycle, is going more and more. Sometimes we go in and we drill only. We just put a hole inside the bone. Why? Just to decrease the pressure. And some patients really get use of that. So vascular stasis, sinusoidal compression, marrow edema, articular occlusion. Again and again, this is for the non-traumatic. So it's either intravascular problems like sickle-cell disease, thrombocytopenia, fat embolism, because these small S-shaped red blood cells are going inside microvessels and they occlude it. So when they are occluded, distally there will be necrosis. Extravascular, which is Gaucher disease, tuberculosis, cortisone abuse, or alcohol abuse. So these are the non-traumatic causes. Okay, usually bone cells die after 12 to 48 hours of anoxia. That's why it's important to diagnose early and treat early. The gross appearance of affected segment to be altered needs days, even weeks. So you don't wait until you see it by the X-ray. So X-ray is late. Histological changes, loss of fat cells outline, inflammatory cells, bone edema, appearance of tissue histocytes, and replacement of necrotic marrow by undifferentiated mesenchymal tissue. So this is a nice picture. This patient is having a problem. It's an avian necrosis, osteonecrosis. Here the articular surface, and usually the articular surface is normal. Normal. Why? Because the articular surface is taking its nourishment from the synovial fluid. Okay, that's why it will be maintained. In B here, this is the necrotic segment of the bone. This is the area of avascular necrosis. Sometimes it's normal in the early stages, then it will get sclerosed more wide, then it will get destructed. After it gets very weak, it will be collapsed. Then the articular surface will be collapsed too. C, new bone, and D, normal. Clinical feature. The earliest stage of bone death is asymptomatic. Unfortunately, it's asymptomatic. Then the patient will present with pain, click in the joint, stiffness, local tenderness, swelling, restriction movement, deformities, muscle wasting, and the more you go with progression, the more worse the presentation is. On X-ray, the early signs usually, you cannot see anything. So you cannot detect anything by X-ray. After 3 months, so after months, after a long time, you will see new bone formation, trabecular failure. So the pathophysiology, increased radiographic densities appearance, which is sclerosis, you will see. Then the subchondral bone will be more weak. There will be microfractures in the subchondral bone. That's why you will see something called crescent sign, and I'll show you now the X-ray. After that, the articular surface will be normal, but when the subchondral space is destructed and fell down, the articular surface will fall down too. It will cause a deformity and problems in the articular surface. So the cardinal feature distinguishing primary avascular necrosis from sclerotic and destructive form of osteoarthritis. These are joint space is remained normal until very late stages. So this is a X-ray, very nice X-ray. Look at here, this is the femoral head. You can see here the joint line is maintained. This small translucency is called crescent shape. So this is crescent shape. You can see here the whitish, more white bone, which is the dead bone, sclerosis. And here it's very late. The joint now is destructed, which is very, very, very late. Imaging, radioscintigraphy, technetium 99. It will give you an idea that there is a reactivation of bone, a hot area. And in sickle cell, you can find it's very cold in contrast because there is no blood going there. If it's inflammation, there will be more uptake. If there is no blood going there, there will be less uptake. MRI is the most reliable way, really, because it's the earliest to diagnose avascular necrosis or osteonecrosis. If you think that this patient is having osteonecrosis, the modality you have used earlier is MRI. So that's why on T1 weighted, you know, MRI, they have T1, T2, and the flare. So how does the MRI work? It depends on the proton, which is H2O. You know, H2O in the body is H plus and O2. So depending on the water content on each tissue, we have the MRI machine, which is the magnetic resonance. We have a field of magnetic field, okay? So what's happening when it gives the radiation, this magnetic field is going around, the protons are moving. When they move in each tissue, depending on the water content, it will give like a reflection on this machine, and it will read it. So it depends on the water content on each tissue. That's why you can find soft tissue easily more than X-ray. Tests intramedullary pressure. So normally intramedullary pressure is about 10 to 20 millimeter Hg. So we introduce a small catheter inside the bone and we can measure the pressure. If it's 10 to 20, this is the normal. And we sometimes inject saline. So it's called saline injection test. So when we inject the saline, it should be raised up to 15 millimeter Hg. The problem when you have osteonecrosis, it can be raised 3 to 4 folds. Okay, so this is the idea of the saline injection test. Venous stasis and similar finding have been recorded in osteoarthritis? Definitely yes. Staging of the lesion, we have the ARCO, the Association Research Circular Osseous, okay? So the ARCO, they have 6 stages. The first stage, they called it 0 because it's asymptomatic. Only histologically you can find it. So stage 0, asymptomatic. Stage 1, X-ray is normal, but in the MRI you can see radionuclide scan shows osteonecrosis. Okay, so it's either MRI or radionuclide. Type 2 or stage 2, on X-ray now, you have early signs of osteonecrosis, but no distortion in bone shape, okay? So we have A less than 15%, B 15 to 30%, C more than 30%. Until now, there is no crescent sign, but in stage 3, as you can see in here, there is a crescent sign now in the femoral head, but still spherical. The articular surface is still maintained. Stage 4, flattening or collapse of the femoral head. So if you are waiting for the joint line to be collapsed, you are in stage 4. Be careful. 5, changes as above, plus joint space is decreased. Stage 6, destruction. Okay, so how to diagnose? History of trauma. You have to look for the diagnosis of, for now we are talking about the underlying disorders for sure. So occupation, what he's working, is he a deep sea diving? Working under air compression, is it important? Yes, and we will talk about it. Family history about Gaucher disease, sickle cell disease, or any drug intake, cortisone, alcohol, combination of drugs, and so on. Alcohol abuse, does it affect bones? Definitely yes. Because patients usually tend to hide this, it's harder to diagnose. There is no biomechanical findings that we are looking for specifically for alcohol, but you have elevated AST, glutamine transpeptidase, serum urate, serum triglyceride, and mean red cell volume. The most important part is prevention and prevention and prevention, okay? Alcohol use, cortisone, these people who are in their occupation, they have to take care. So we have to prevent anoxia, especially if your patient is having sickle cell disease, be careful for anoxia. Treatment, early osteonecrosis, conservative. Intermediate, sometimes we have to do realignment osteotomy because if we keep the pressure on this bone, it will collapse. So we do something called realignment osteotomies. Late stages, sometimes we do non-operative management, sometimes we do arthritis or total joint replacement. Systemic disorders associated with osteonecrosis. Who are the patients who will get osteonecrosis? Drug-induced, sickle cell, Caisson disease, Gaucher, radiation necrosis, osteochondrosis, and finally SONK. So drug-induced, alcohol, corticosteroid, immunosuppressive, depending on the dose and the time they've been taking the drug, and some predisposing factors. Sickle cell disease, again, because it's small, closing the arteries, it will give osteonecrosis. Be careful of hyperuricemia, and they will get bacterial infection. And the organism of choice on these patients is Salmonella. Common questions for the patient, for the people who are getting STIPs, the USMLEs, they will ask you, a patient with sickle cell disease, he got osteomyelitis. What is the most common organism? The answer is no, not Salmonella. It's still Staph aureus. But Salmonella, the risk for these patients is higher than normal patients. Okay? The difference is the American Academy for sure. Osteonecrosis of the femoral head is very common, especially in Perthes disease. In children, you can think it's Perthes. What's Perthes? We will talk about it in the pediatric. The child develops pain and limping usually. Caisson disease. So Caisson disease is when you have someone who's swimming under like 15, 20 meters in the sea, they have a lot of pressure inside. This pressure, okay, will saturate the fat, especially with nitrogen. So it will cause local damage, it will cause embolization and intracapillary coagulation. So these patients will have this disease. Another problem that there is decompression sickness. What's decompression sickness? If a swimmer is under the sea and he's seen a shark, there is a button they can press. It will inflate the balloons on their back and they will jump up in the air immediately. So this is called decompression sickness. From high pressure to low pressure, it will give them a lot of problems. It will give them visceral injuries, pain in the joints, difficulty in the breathing, sometimes a pneumothorax. So they might have a lot of problems and severe neurological changes, even coma and death. That's why they put them in a chamber sometime. It has a high pressure and they start to decrease the pressure immediately. The problem, the prognosis is very bad sometimes. Medullary infarction, motile calcification, management. The most important management is to do prevention. Gaucher disease, familial disease, okay? It's lack of specific enzymes, abnormal storage of glucosorbide in the macrophages. So this is the Gaucher disease. Is it important for orthopedics? Yes. It affects the liver, the spleen, the bone marrow, okay? The problem, it will give you osteonecrosis, okay? In the hip, talus, distal femur, and the head of a humerus. So they have specific findings you will see on X-ray, which is called Erlenmeyer flask appearance. So you can see here in the metaphyseal region, it's called metaphyseal flaring, okay? So you can see Gaucher deposition here in the bone on picture A, you can see bone infarction on B, you can see the metaphyseal flaring or Erlenmeyer flask appearance, which is for Gaucher disease. intramedullary nail or rod. And you can see the appearance of Gaucher disease in here. Treatment, replace the missing enzyme. Okay. And for osteonecrosis, the principle we already talked about is the same. Radiation necrosis depends on the ionizing radiation. It depends on the how much did he get the radiation and the quantity. So it's important to know these informations. Area affected usually are the shoulders and the ribs, and they may cause breast cancer, sacrum and pelvis, and the jaw, because these are the most places that are affected. Pathology, radiation necrosis is more diffuse and more valuable. Marrow and bone cells die. The problem that they die and they will give you sclerosis on X-ray, but for months or even years. So that's why the patients who are working on these places, they don't realize, or they think that, oh, it's easy, we've been working for months and nothing happened. It's accumulative, so be careful. Usually they will have stress fractures. A striking feature is the absence of repair and remodeling. So the bone is not doing remodeling. So dying, there is no remodeling. Pain. What's the treatment? It's the same. It's the same. You have to alleviate the patient's pain. Okay, if it's a large joint, you can go for arthroplasty. Otherwise, sometimes you go for arthrodesis and so on. Osteochondritis, okay, it's like separation and necrosis. This is chondritis, separation and necrosis. So in the subchondral lesion, you will find avascular necrosis and separation. It depends on the fragment. It depends on the fragment, how much it's big. Okay, if it's small, sometimes conservative. It's sometimes you can go in with a scope and fix it back. If it's huge, you can also fix it. So it depends on the joint and the complications and the signs and symptoms of the patient. Okay, so what to do? Because he's having pain, painkillers and crutches. If it's in the knee or the ankle, give him crutches, so decrease the weight bearing on this limb. You can go for arthroscopy. Yes, you can fix this piece if it's loose. What's SONK? It's spontaneous osteonecrosis of the knee. Usually it's happening in the medial femoral condyle. Okay, it appears in the elderly people, osteoporotic, and in MRI you can see here the changes on this part of the medial femoral epicondyle. It's uncommon. Okay, it will give you transient osteoporosis. Typically it stays from 6 to 12 months. The symptoms usually subside and the bone is getting restored. Successive joints are affected, regional migratory osteoporosis. The etiology of this condition is obscured. This is a comparison between the bone marrow edema and the osteonecrosis, and you can check the this table on your own. So this was like just basics, the most common diseases that will cause you osteoarthritis and osteonecrosis. And thank you very much.